After all the conference highlights and recent FDA approvals, we're back to our treatment algorithm discussion. And today we're focusing on head and neck cancer. Hello and welcome back to the Oncology Brothers podcast. I'm Rahul Gosain, here as always with my brother and your co-host, Rohit Gosain. Over the next 20 minutes or so, let's appreciate the current treatment landscape for head and neck cancer, but also address some common questions that we often face in our clinic, such as what is the data for high dose versus weekly cisplatin in this disease? How's HPV-positive disease behaving differently? What is the role of immunotherapy and anti-EGFR here? Is the sandwich approach of periop immunotherapy and post-op immunotherapy now the new standard of care? To walk us through all this, we're excited to have Dr. Fangdi Sun, a head and neck medical oncologist from Stanford University. Fangdi, thanks for joining us.
Thank you so much for inviting me. I'm so excited to talk about head and neck cancer because there's really been a number of changes in recent times, and hopefully we can talk about all that.
Indeed, Fangdi. Thanks so much for joining us again. So, going over a broad overview where we stand for oral cavity in general, surgery is the main modality for a limited stage. And if one is diagnosed with oropharyngeal, we focus more on organ preservation, especially when larynx is concerned. So, as a result, chemoradiation approach. And for nasopharyngeal, multimodality is what is utilized. So, Fangdi, for someone with suspected head and neck cancer, what is your initial workup and any role of biomarkers here? And importantly, NGS upfront. Are you doing that at all?
In terms of diagnostic workup, I think about it in probably three main buckets. The first of which is, most of us will really prefer to be able to directly visualize the tumor if it is in an area that we can see. Oftentimes in the oral cavity, you may be able to see those tumors directly on your physical exam, but for many of these cancers, this is going to require a fiber optic scope. Often our ENT surgeons and other providers are able to provide that for us. In terms of imaging, we think of two components, anatomic imaging at the primary site and the neck. So our preference is typically an MRI scan of the head and neck with contrast. And if we cannot get that, or sometimes it's complementary to also get a CT scan. Most of us in the academic resource-rich setting will admit that we do typically get PET-CT scans for systemic imaging. In many cases, a CT scan of the chest could also be sufficient for that purpose. When it comes to biomarkers, there are a few things we definitely check, but I will admit this is an area where, I hope to have few additional developments in the future. One that's absolutely critical is IHC for P16, used as a proxy for HPV status in oropharynx primaries, which is absolutely required for oropharyngeal cancers. Some places will also do in situ hybridization for high-risk HPV. Now, you mentioned the use of immunotherapy in the early stage setting, which we'll talk about further. Because of that, we now check PD-L1 IHC across the board in both early and advanced stage disease. Now, when it comes to NGS, I think this is probably a wish for the future when it comes to head and neck cancer in most cases. At the end of the day, most of these are squamous cell cancers. Akin to squamous cell lung cancers, there have not been many actionable targets here. So while we do occasionally send it in, particularly in the advanced setting for diagnostic, sometimes later stage therapy purposes, it really does not end up being actionable in most cases. I would not consider it a standard part of the diagnostic workup.
As a generalist, when we're dealing with breast cancer, lung cancer in our clinic practice, we're often getting NGS upfront for a lot of these disease sites. But head and neck is one site where we're eagerly looking forward for actionable mutation. Even in my practice, the role of NGS here is very limited. But going back for early stage here, we're often relying on surgery, and adjuvant treatment is dependent on those high-risk features. For locally advanced disease, we as medical oncologists play a bigger role. After your initial workup, can you walk us through your treatment algorithm? You touched on the importance of HPV testing. How is that playing a role? How is the tumor behaving differently for HPV positive versus HPV negative disease?
Yeah, this is such an important point to emphasize because HPV positive and negative cancers really are so distinct in many ways. If you think about risk factors for HPV negative cancers, we're thinking about classic factors like alcohol use, smokeless tobacco, cigarette smoking, and overall the prognosis is much worse for these cancers as a whole. Whereas for HPV-positive cancers, we're talking about high-risk HPV, vaccine-preventable disease, typically a younger age at diagnosis and an overall better prognosis. If you think about oropharynx cancer, HPV negative and positive are distinct staging systems. And because of that, the branch point in treatment is actually quite different. And, we'll break that apart a little bit more. The schema you have shown first here is specifically what I would say is most applicable to HPV negative mucosal head and neck squamous cell carcinomas. And I think we'll touch on a little bit later how HPV positive differs and how that's much more reliant in the oropharynx site on chemoradiation. So in many situations, either definitive chemoradiation or adjuvant chemoradiation after surgery based on risk factors, as you emphasized, we are picking a systemic partner, and we think of that systemic partner as a radiosensitizer to help the radiation work better, is what I tell patients. As you've alluded to, cisplatin is and does remain our preferred radiosensitizer. There are traditionally two ways to administer that. One is high-dose cisplatin every 3 weeks, usually about 2 to 3 doses. The other low-dose, 40 mg per meter squared weekly, typically somewhere between 5 and 7 doses. There is an ongoing cooperative group trial in the US directly studying those therapies head-to-head. However, I think many of us in this country have shifted towards more of the weekly dosing, in part because in the adjuvant setting, there are data from the Japanese cooperative groups that those regimens are associated with lower risks of permanent hearing impairment and kidney injury. So I think many of us for cisplatin lean a bit towards the weekly dosing, although neither is proven to be better. What do we do when someone's cisplatin ineligible? We have, direct data in the HPV positive population that cisplatin radiosensitizer is superior to cetuximab, and that's one of the older RTOG trials. We have retrospective data that carboplatin-based regimens, of which weekly carbotaxol is a common one, is probably somewhere in between cisplatin and cetuximab in terms of efficacy. However, we don't have true level 1 evidence to show where in the hierarchy the carboplatin regimens sit, although I think many of us think of them as somewhere in between, as I mentioned. In the definitive or curative setting, the newest data we have is from the Keynote 689 trial. This trial specifically looked at patients with locally advanced, so stage 3 to 4A mucosal head and neck squamous cell carcinoma that was resectable up front. And in those patients, they were randomized to either perioperative pembrolizumab for a year versus control, all overlaid upon the standard of care of surgery followed by adjuvant radiation or chemoradiation. This trial did meet its primary endpoint, so it did show an improvement in event-free survival with a hazard ratio of about 0.7. As for this isn't yet mature. And, what this ends up looking like and has been FDA approved is 2 cycles of neoadjuvant pembro amongst patients who are PD-L1 CPS 1 or greater, followed by surgery and then adjuvant pembro along with radiation or chemoradiation, as we usually do. Now, I want to be really careful about what this trial does and does not represent. The FDA approval is PD-L1 positive only, in part because there were less than 5% of patients with PD-L1 negative in this study. And then secondly, this is not a study of HPV positive disease. Really, all the patients, except for about 3%, were P16 HPV negative. I would not use such a regimen amongst the P16 HPV positive population. The other thing that is playing out in real world practice is patient selection for such a strategy. At the end of the day, this is neoadjuvant pembro. The response rates are not perfect, and we end up losing some patients who aren't able to make it to surgery. There will be further intensified neoadjuvant strategies in the future. There's a lot of discussions at tumor boards these days about if a patient is appropriate for this regimen, particularly if they're currently resectable, but may not be resectable if they were to have tumor progression on the neoadjuvant pembrolizumab.
And when combining pembrolizumab in adjuvant setting, are you waiting for radiation to get over or combining that with chemotherapy? How are you maneuvering through that?
So with this particular perioperative regimen, the pembrolizumab was started at the time of adjuvant radiation. Patients are receiving it both with radiation and for that tail afterwards to finish out the 1-year course.
Rohit, I think the reason why you're bringing that up is initial data of concurrent radiation and immunotherapy. We all got spooked saying there might be higher toxicity, but we've seen even with our lung cancer trials that has thankfully not played out. We're not seeing higher toxicities even when we're combining immunotherapy and radiation here together. And right now it's three of us, three medical oncologists, but head and neck cancer is also one place where outcomes and survivals, and including your quality of life, is so much better with multi-D approach. And here I'm not just talking about radiation or surgery, but having that nutrition and speech on board as well to ensure our patients can get through these treatments well is very, very important. Before switching gears to metastatic disease, Fangdi, when monitoring these patients after their definitive treatment, how frequently are you monitoring scans? Role of CT chest during surveillance? Is there any role of HPV DNA titer if this is HPV positive disease?
You are asking some excellent and also very provocative questions in some sense. Particularly for the patients getting chemoradiation, it is quite standard to get repeat imaging around the 3-month mark after they finish that therapy, in part to allow time for the inflammation and healing after that therapy. For many of us, that will mean an MRI scan or CT scan, whatever you got up front, plus a PET CT for systemic imaging. If there is anything equivocal on those scans, sometimes we will repeat again at about 6 months. But honestly, for most patients in our setting, we end up, sort of stopping the standard imaging around 3 months. From there on out, our surveillance is largely endoscopic and by physical exam in places where that may be less accessible. I don't think it's wrong to get additional imaging. We've just never shown in a standardized manner that it's beneficial to get that imaging. As for the HPV blood tests or DNA tests, there are a number available commercially, and I think even more in development. One important point to emphasize is that not all patients have positive HPV DNA in the blood at baseline, but it is helpful to understand if you are going to use this test, whether that test is positive to begin with, if you're going to use that in surveillance. Some of us are using it. In our case, many of these are part of a research protocol. I do not think it is yet standard, but it may help clue you in towards people to be more careful about surveillance and do some additional targeted imaging if you'd find a positive test in the surveillance setting.
Thanks for touching on this HPV DNA titer story. I feel like it's very similar to what we are doing for colorectal cancer, which is ctDNA. We'll see how the prospective trials play out in this arena. Now, focusing on metastatic space, how are you utilizing systemic therapy, especially when we are talking about the PD-L1 score? One has to divide this in PD-L1 negative versus PD-L1 positive. And in PD-L1 positive, are you utilizing pembrolizumab as a single agent or along with chemotherapy?
So our first-line therapy for metastatic disease or disease that we don't deem resectable and doesn't have a definitive option is really based on the KEYNOTE-048 study, which is now about 5 or 6 years old. That study actually had 3 arms: pembro monotherapy, pembro with chemo, or the reference standard at that point, which was cetuximab with chemo. From that, we came to understand that overall survival in patients who are PD-L1 1 plus or greater was improved with pembro alone compared to the control of cetuximab with chemo. We learned from that study that overall survival in the overall population was better with pembro and chemo compared to the control arm. For patients who are PD-L1 positive, so 1 plus or greater, we technically have the option of either pembro monotherapy or pembro with chemo. How do I choose between the two? There is practice variation here. How I think about it is that if you look at the median OS between pembro monotherapy and pembro plus chemo, they actually end up being pretty similar, around 12 to 13 months. The difference I really think about is the response rate for these regimens. So with pembro monotherapy, it was close to 20%, whereas pembro plus chemo, it was closer to 35%. So if I have a patient in whom I'm really worried about tumor growth causing worsening symptoms or just putting them in a bad place, I will lean towards pembro plus chemo in the PD-L1 positive group. Whereas in many other patients, we are able to get away with just pembro monotherapy alone, which certainly has fewer side effects by itself. Now, the PD-L1 negative population is a little bit harder. Many of these studies are analyzed sequentially. They start at the PD-L1 high populations, expand each step of their statistical analyses. So our actual understanding of the negative population is not great. We do still have the option of pembrolizumab plus chemotherapy, but many of us will still consider cetuximab plus chemotherapy as well, which was the reference regimen in that Keynote 048 study.
In a patient that has PD-L1 positive disease and is on monotherapy pembrolizumab, at the time of recurrence, do you add chemotherapy and continue with your pembrolizumab, or do you often drop pembrolizumab and move on with chemotherapy alone?
There's not a perfect answer to that. It depends to some extent. If a patient has been on it for a while and, clearly has progressed, unequivocally, we will mostly switch to chemotherapy, and often that chemotherapy will pair with cetuximab. There are, I would say, rare situations in which I have given a patient a few doses of pembrolizumab, towing the line between pembro versus pembro plus chemo. And, things are not going as well as we would like. Sometimes we will add chemo to those situations, but I would say that is a case by case situation.
Thanks for covering that, Fangdi. Now, focusing on HPV-positive oropharyngeal cancer, if you can go over how the treatment differs here versus HPV-negative disease, and also role of HPV vaccination in prevention here, especially when CDC guidelines are wishy-washy from the group of ages 27 to 45.
Yeah, I think the two things to really emphasize for oropharynx cancer, and particularly HPV positive disease, is one, that it is particularly radiation and chemotherapy sensitive. So, particularly in the local regionally advanced setting, this is a chemoradiation disease, and we try to lean away from surgery because of the morbidity associated with treatment. In terms of vaccination, it is true that vaccination is more strongly recommended for those who are younger because of the typical age of sexual activity exposure and HPV exposure. For our individual patients, I do take this as sort of a local opportunity to educate their community and people around them that this is very much a vaccine preventable disease with a relatively well tolerated, safe vaccine. At the end of the day, it often comes down to insurance coverage, but if a patient or their family member is able to get it covered, I do recommend it for future prevention. Not in the individual patient who already has the cancer, of course, but potentially in the family members and those around them.
Indeed, partnering up with our radiation oncology colleagues is extremely important because of the responsiveness. Before we close, we definitely want to touch on nasopharyngeal, which is a huge subset, but the treatment differs here slightly, and it's rather a bit unique. For early stage, that is T1N0, we see a role of definitive radiation therapy alone and adding on to chemotherapy if the high-risk features are present. And for T2N0 or stage 1B, concurrent chemoradiation therapy is the way to go. For stage 2 or 3, we have the role of induction and then followed by consolidation therapy. And then the questionable role of adjuvant capecitabine. Your thoughts around this? Are you utilizing adjuvant capecitabine for all your patients or some of the patients?
That's a really good question. The paradigm of induction systemic, which is typically preferred over adjuvant, and that's most often gem-cis, followed by concurrent chemoradiation, is well established and supported by, international guidelines. When I'm talking about nasopharyngeal carcinoma here, I'm really referring to EBV positive disease. Very often on tissue, we're doing in situ hybridization. Most of the studies I'm referencing are all done in endemic regions where essentially everyone is EBV positive, and so there's no reason necessarily to test. But in our US populations, it is very important to have that testing. Adjuvant capecitabine is really interesting. Specifically, this is adjuvant metronomic capecitabine. Instead of the 2 weeks on, 1 week off that you might be used to in, say, breast cancer, this is given continuously for an entire year at a slightly lower dose. There's a trial from about 4 years ago that showed improved overall survival, well as failure-free survival in such a population. I do routinely recommend it in my practice. However, I will admit that it is not universally accepted despite this evidence. This is in part because there are ongoing studies which are looking to move immunotherapy into the local regionally advanced setting in NPC. The caveat there, however, is although many of those studies currently appear promising, none have yet demonstrated overall survival benefit and none are yet, officially approved in that setting. In my mind, immunotherapy remains exploratory in early stage nasopharyngeal cancer, and capecitabine, with its overall survival benefit, continues to be something I recommend in this setting.
All right, now on to advanced or metastatic nasopharyngeal disease. And Fangdi, thoughts on monitoring EBV titer here?
Yeah, excellent question. The paradigm here, if you think about what agents we're giving, is not that different from some of the other head and neck cancers, but the specific agents to some extent actually are. This is a cisplatin gemcitabine backbone with PD-1 inhibition, and the specific PD-1 inhibitors approved here are toripalimab and pinpulimab. Now, EBV titers is a very interesting question. You had mentioned before that for those very small tumors in which we're thinking about radiation or chemoradiation, we use it and we'll think about it. But even there, the exact threshold cutoff is not necessarily standardized. In the advanced setting, there are many who will check it. But to be honest, I very rarely make actual treatment decisions based on changes in the EBV titer. My preference in general is not to check it unless I'm looking at someone in surveillance and trying to use that as another piece of my surveillance plan after definitive treatment.
And then, as we close, any final thoughts for our listeners when treating head and neck cancers?
Yeah, I think a few important things to emphasize. Multidisciplinary collaboration is so key in head and neck cancer, almost more so than any of the other disease sites in oncology. So many of our treatment decisions, particularly in the definitive setting, are really patient and disease specific in a way that isn't captured by staging systems or risk models. Even the definition of resectable is very much patient specific based on values and organ preservation. The other thing that we already emphasized is to check for key biomarkers. In some cases, like the oropharynx, this is absolutely required for diagnosis in terms of P16. And PD-L1 now is something that we use in both the early and late stage settings. And then I think lastly, it's just a very exciting time in head and neck cancer. We have a new perioperative approval, albeit imperfect. There are new therapies in the advanced setting in clinical trials, a number of which I think will soon emerge, hopefully in the clinic as well. And so we hope that very soon we'll have additional options for our patients, both early and advanced stage.
Absolutely. Yeah, now this is, again, one disease site where multi-D definitely has to be at the center of all what we're doing. Fangdi, thank you so much for walking us through the current standard of care in head and neck cancer. For our listeners, let's do a quick recap. In today's discussion with Dr. Fangdi Sun from Stanford University, we covered the treatment algorithm for head and neck cancer, starting with initial workup, including the importance of HPV testing and EBV testing. For early stage disease, surgery or definitive radiation is the key, with adjuvant therapy based on risk features such as positive margins.
In locally advanced settings, concurrent chemoradiation with cisplatin remains the standard, with some nuances for HPV-positive oropharyngeal cases. For metastatic disease, IO chemo combinations are leading the way. We also touched on imaging for monitoring, supportive care integration, and the selective role of expanded molecular testing. Finally, we also highlighted specifics of nasopharyngeal cancer.
Thanks again for joining us. Stay tuned for future episodes as we continue to bridge the gap in oncology. We are the Oncology Brothers.